I wanted to give the readers the sense that one of the reasons why we haven't had as much progress, I think, in healthcare is because we're always looking for the quick fix.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. We are honored to have Dr. Vivian Lee for the Business of Healthcare podcast. Dr. Lee is the author of a new book, The Long Fix, which will be released this month. She's been a practicing physician, scientist, and healthcare administrator for more than 2 decades. Currently, the president of health platforms at Verily, which is Alphabet's health company. She's a senior lecturer at Harvard Medical School, formerly the dean of the University of Utah School of Medicine, and the CEO of the University of Utah Health, a system recognized for its excellence and innovation in care. Welcome to the podcast, Dr. Lee.
Hey, it's wonderful to be with you. Thank you.
So I was glad to receive a pre-release of your book, The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone. Some people binge on Netflix for home entertainment, but this past weekend, I binged on your new book. It is quite compelling and resonates with so many of the things we teach in our graduate program for doctors and administrators. I want to get to some of the key points and principles of the book today, but I also want you to take a few minutes to share with our audience the journey you've been on from MD to CEO. You are currently the president of health platforms at Verily, Alphabet's health company. The book does a wonderful job of storytelling. You leverage the insights from 2 decades of experience in leadership roles. How did it all start?
Well, that's really a wonderful introduction. Thank you very much. And I start the book, The Long Fix, with the story of how I first came to know a little bit about healthcare, which actually was when I was in junior high school, and a very resourceful teacher of mine tried to match us up with various community leaders. And just randomly, I really lucked out. I was assigned to Dr. Hal Belknap, who was a general internist in Norman, Oklahoma, which is where I grew up. And for the next several years, every Saturday morning, I'd go over to Norman Regional Hospital and I would shadow him. I'd just tag along as he went on rounds and visited with his patients. And he was really the consummate physician. He was a brilliant diagnostician. He didn't rely a lot on tests or imaging studies, just really had a great set of instincts and really great knowledge and wisdom. And he was a real people person. So he would sit down at the edge of the bed and just chat with people. And just by listening to their concerns, formed a really wonderful connection with them. And it was really starting from that point that I thought, well, this is something that feels so rewarding and feels so important and feels so meaningful, even though, of course, I didn't understand most of the medical terms that he was using. And it was at that point that I decided that I really would love to become a doctor.
I see.
Along the way, there were a few bends in the road because I also really loved engineering. And so on my way to medical school, did a graduate degree in biomedical engineering, and never expected at this point in my life that it would come back into the way of thinking, but it actually did. In my career, I am an MR radiologist. And I started off really interested in, and maybe that MR radiology is a reflection of that engineering and healthcare interest, sort of the convergence, but pretty reluctantly got pulled into administration. Can't say that I really started off my career thinking, oh, I want to just manage a bunch of people and lead some complicated organization. I didn't have that in my mind at all. But when I was at NYU as a junior faculty member, I was teaching, I was practicing, and I was doing research, and I was really enjoying the research in MRI. And we got a new chair of the department, Bob Grossman, who moved from Penn, came over to NYU, and we'd heard about him. We knew that he was really a superstar, but we just could never have imagined the transformative effect he had on first our department and then on the entire medical school and medical center. But when he came over, I had just gotten my first NIH grant. And it was sort of that old adage in medical school or in medicine, see one, do one, teach one.
Yes.
Well, he said, well, you got yourself a grant, and we would love to have more physicians in our department get grants. How about you become the vice chair for research for the department? And I said, well, Bob, I've only really just got my first grant. But he had a lot of confidence, and he was really a wonderful mentor. And so I found myself drawn into this idea of, well, there are a lot of really interesting research questions that are happening. How do we equip scientists, both MDs and PhDs, with the right tools to get there? And I think really starting then, I began to think about what does it take to bring out the best in people and to equip them with the tools and the resources and the support to enable them to do what they really, really want to do. And I guess I would say that sort of pulled me in, starting in research and then moving into healthcare writ large, which was how can I help support health systems that really want to deliver better care, integrate research in, integrate education in, and do it in a really fiscally viable way, which is a challenge in healthcare. So that's kind of a long-winded answer of how I started really thinking about healthcare itself from the vantage point of starting as an administrator in research, and was drawn to Utah in a very serendipitous way. I had been reading a book called Designing Care about healthcare, and it was a book by a man named Richard Bomer, a fantastic physician leader also, and he wrote about Intermountain. And Intermountain Medical System is a really impressive medical center in Utah. So I'd been thinking about paying a visit just to learn more about them. And then at that same time, that year, among all the university hospitals in the country, we're ranked every year by quality and safety. That year, NYU was number 10. The University of Utah was number 1. And I was really intrigued by that too. And just as I was trying to persuade everybody on the NYU C-suite that we should do a field trip over to Utah to study the university and to study Intermountain,
right,
I got this call from a search firm. And the search firm said, why don't you come out and interview for this job? It's the preeminent academic medical system of the region, also very close partners with Intermountain. So if you come out, you can have your field trip, and what harm can it do? And the next thing you know, they offered me the job, I took the job, and I was leading this large integrated health system in Salt Lake City.
Wow. I know from the acknowledgments in your book, it's all about relationships and the people that you connect with in a meaningful way, the mentorship that takes place, both giving and taking. That's really been a key element, I think, of your success. And the story goes on and on. Let's change topics here. The name of the book, The Long Fix, which is already available for pre-order on Amazon. It's an optimistic book about saving America's health crisis, okay? Solving it, really trying to get things back on track. And, there are a lot of books that define all the different significant issues and problems in healthcare. Tell us more about the context of the name, The Long Fix.
The name really came about only at the very end. And it happened because of a conversation that I had with Mike Leavitt. Mike Leavitt, Governor Leavitt, the former governor of the state of Utah, former Secretary of Health and Human Services under Bush. And I had a conversation, and I talk about him actually in the book, this interview, where he's reflecting on the arc of healthcare reform and just how long it really is, and speculating that it would take something like 40 years for us to really see significant improvement and change. And he started with, in this particular era, the 90s. He started talking about it in the context of a book that he had been reading about how long it took, for example, for major transformations and major advances in the computer science industry based on a recent book by Walter Isaacson as well. I wanted to give the readers the sense that one of the reasons why we haven't had as much progress, I think, in healthcare is because we're always looking for the quick fix. We're always looking for the simple answer. What's the one thing? What's the one thing we could just fix? And boom, magically our healthcare system would be perfect. And of course, it's so complicated. You know this better than anybody. You're teaching this to your students. And so I wanted to give the sense that this was something that would require more input from broader sources, that more buy-in, and that it wasn't something that was that simple. But I absolutely wanted it to have this optimistic tone, which I personally do feel, which is that it is solvable. There is a fix at the end of this. Today, in the COVID crisis, I actually am hoping that it will be the not so long fix, because we'll be able to accelerate some of the changes that we know are needed and that I write about in this book. Because as Churchill says, never waste a good crisis. And I think that there are opportunities now for us to accelerate some of those changes. But nonetheless, it is complicated and it's definitely not a quick fix.
Yeah, I really like the framework that you presented in, because the quick fix, nobody has faith in that. And we know that it takes a lot of effort and a lot of people, a lot of time to manifest these type of changes. And it's unreasonable for us to try to cover the whole dynamic range of topics that are presented in the book during the short podcast sessions. There are so many major themes, so we're just going to try to touch base on a few of them. In our curriculum here at the university, we cover topics on value-based pricing, transparency, virtual health, quality process, big data, pharmaceuticals, and you go deep on all these topics and many more. The Long Fix, I can tell you, it's going to be a standard pre-read for our healthcare leadership and management programs here.
Oh, thanks, Bob.
I believe in what you've presented in such a coherent way. It's got to be part. It's letting everybody know here what we're doing. You're doing that in the book as well. But so one of the big things you talk about, and I would like for you to kind of discuss that now, is moving from paying for action to paying for results. Paying for action, we a lot of times refer that as, fee for service. You like to refer to it as paying for action to paying for results. Explain how important this is in the role for the patients, the providers, the payers, and the policymakers.
Thanks for that question. This is really, I think, the core concept that is important for everyone to understand, which is that the fundamental business model of healthcare in this country is flawed. That in a fee-for-service model, what we are essentially doing is incentivizing more actions to be done to patients, whether they're operations, procedures, imaging studies, and so forth, regardless of whether they improve health or not. It's not that all of us as physicians overtreat deliberately or overdiagnose. Most of us are trying to just practice really good medicine. But nonetheless, the economics of the entire healthcare system are set up to incentivize and reward overtreatment, overdiagnosis. And as a result of that, the only control point in the system has turned out to be now the insurance companies and payers. So what do? They set up processes to try to reduce that spending and reduce that ordering and that treatment, whether it's prior authorization or denials of care or increased co-pays or increased co-insurance. They try to put up barriers. And so what you have at the end of the day is this $1 trillion, what I call a $1 trillion tug of war between provider systems, physicians, hospitals, and so on, and insurance companies, payers, ordering a study, denying a study, requesting a referral, putting in a prior authorization barrier. And it's led to an enormous amount of waste. As you know, the American healthcare system spends about 8% of our healthcare dollar just on administrative tasks, whereas most OECD countries, for example, only spend 3%. That's an enormous amount of waste, and it's a huge amount of headache.
Yes.
Significant driver in burnout. As a result of this, we've now created a system that is a tug of war between huge behemoths, and the patients are just caught in the middle. And when we can't resolve this, that's what leads to these surprise bills, balance bills that are hurting everybody. And so we really have created a system where I like to say that we're flying into the headwinds of capitalism with our current healthcare system. And what I mean by that is capitalism has really served our nation very well. It just has driven a lot of innovation, has really driven a lot of the economic success of this country. But the way in which healthcare is set up, we're really encouraging innovation in the direction of simply doing as much as we possibly can to patients. So we're flying in the headwinds of capitalism, whereas newer payment models where we actually are paid for better health
yes,
can completely flip this model on its head, and we can start to actually experience the tailwinds of capitalism. And some of the examples that I point out in the book are with some of the new Medicare Advantage contracts with medical groups like ChenMed, like Iora Health. Those are a couple that I share stories about in the book, where those medical groups are paid per member per year, Medicare patients, to keep those patients healthy. They're paid a fixed amount of money, and those physicians have the autonomy to decide how best to spend that money to keep the patients as healthy as possible. That's really how you want to be rewarded. That's what I would like for my own family members, if we were paying healthcare systems to keep them healthy. And what did they do with that? Instead of rushing people through visits, they actually spend 30 minutes to an hour with each patient. They invest in on-site pharmacy. They have Tai Chi and yoga classes, and they even set up little community centers to keep people from feeling lonely and socially isolated. And while the primary care part of their practice is more expensive than an ordinary primary care practice to run, at the end of the day, because they are able to reduce hospitalizations by so much, it really overall saves money for the healthcare system. So it creates a win-win-win. And that's an example of where, just by simply pivoting the economic model of healthcare, we're able to leverage innovation, leverage the autonomy and creativity of our physicians who really do want to do good, and nurses and their entire practices, in order to get alignment around paying for better health.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So let's bring the patient into the equation here. You mentioned that for the most part, healthcare is a service, and the patient's role in producing their healthcare can outweigh any physician or nurse's role. And I really like this concept. You refer to the most powerful drug, co-producing your health. Please unpack that concept. I believe it is most powerful.
Thanks for asking me this question. This is one of my favorite concepts, and one of the areas which gives me the most optimism that there is an actual fix at the end of this journey, the long fix. The idea of co-production actually came about in the 1950s. There's an economist named Victor Fuchs who is still teaching at Stanford. And he introduced this idea as the U.S. economy was shifting from more of an industrial economy to more of a service economy. And so he pointed out that in an industrial economy, the relationship between the provider or manufacturer and the customer is very different from in a service economy. In a manufacturing economy, you produce something, you hand it over to the consumer who then uses it. In a service economy, it's much more about the provider of the service and the consumer of the service working together. So examples of that include, for example, if we think about security, we lock our doors. We also, of course, expect the police to help protect us, or we install smoke detectors as a part of preventing fire. Education, we tutor our kids, or we go to PTA meetings and so on, in addition to the school, what the school and educational system can provide. Well, healthcare is actually the same. Although we've been thinking a lot about it as a manufacturer, we sort of think about, we provide as doctors the health for you. But in fact, we know when we think about ourselves as just individuals that the vast majority of health actually is determined by our behaviors outside of the 4 walls of the clinic and the hospital. It's really what we eat, what we drink, if we inhale anything, how we exercise, how we sleep. our social interactions, those really are a much bigger driver of our overall health than what happens with our health systems for the most part. Of course, in the ICU, it's very different, but for most of our health, that would be true. So the idea of co-producing health, I think, is really powerful because it encourages health systems to look out beyond our walls and to say, what can we be doing to help our patients really manage their health better in their own environments and in their own communities? And it's also really a matter of putting our minds, it's the ultimate goal of so much of what we teach in medical school and what we hope our medical students bring when they enter school and training, which is empathy.
That can be a big factor too.
That's right. It's about thinking about what's important to the patients themselves and how we can help them to achieve that, because health is important to all of us. But understanding how individuals can achieve that in their own homes and in their own lives, as busy as they are and as hectic and consumed by other things they are, how we can help them co-produce their own health, I think, is one of the most important things that we as providers can be really thinking about.
So my acronym for being a co-producer is NRA, nutrition, rest, and activity. And that sounds really simple, but if you can, feed your body with the right kind of nutrition, and if you get the ample rest and you have an active lifestyle, I think all that works in your favor, and you just need to develop, some type of system that can reinforce that. And what you so pointedly point out is that it has to be a co-production. Someone else isn't in charge of your health. Together, we're in charge of it.
That's right. I do think there is just to add one thought to that, if it's okay.
Sure.
Because I think you've pointed out you've made a point that reminds me when you say nutrition, rest, and activity, that one of the things that we can think a lot about doing is introducing or taking advantage of technologies that are out there. And we all know that when we lecture our patients about getting more exercise, sleeping better, not sure how much it sticks with most people. It certainly doesn't stick with me when I hear somebody else tell me to exercise more. So how do we use technologies, use social connections with others to really help people achieve the goals that they have? And one of the areas that we've worked on in the company that I work for, Verily, has been in helping people with type 2 diabetes. And we've learned a lot about how to help people, whether they have diabetes or not, frankly, eat in a more healthy way. And I found that just really fascinating. So, for example, we have a continuous glucose monitor, which enables people, you put it on your arm or on your abdomen, lasts a couple of weeks, and it just measures your blood glucose 24/7. And when you can see it on your phone, your blood sugar tracing, and you can actually match that with the foods that you're eating. In this case, you can just take a picture of your meals and your snacks and make that association. That kind of feedback is the kind of feedback I think that we've seen both personally and in others. We've seen how much that can actually influence your behavior. So it's not just telling us to stop eating junk food or eat more salads and fruits. It's actually seeing what it's doing to your body that can be really transformative.
Yeah, you have your own personal valet looking out for you with tools like that. That is incredibly powerful. So we're going to have a few minutes left here, and I want to close on a couple items here. And I know that big data is at the core of what you do at Verily. And most people in our audience are familiar with Google. G is for Google in the alphabet parent company. That would mean that V is for Verily. Give us a quick education on what's happening at the health platform at Verily.
Sure. So Verily Health Platforms is a part of Verily Life Sciences. And as you mentioned, Verily Life Science was purpose-built to commercialize life sciences and healthcare as part of the Alphabet family. And within Verily, within the health platforms part, we're really very focused on how we can leverage technology, all kinds of technology, to try to improve health. And we're very much mission-driven, very much focused on the quadruple aim around how we can improve outcomes, reduce cost of care, improve access to care for everybody, and to do it in a way that provides a great experience for providers and patients alike. One of the examples is in our product that I actually started to talk about earlier, which is this Onduo product around chronic disease management for people outside of the walls of the clinics and hospitals to enable them to manage their type 2 diabetes on their own, which includes not only the hardware of the continuous glucose monitor and the app that enables them to look at their blood sugar tracings in their food, but also text with a health coach, video conference with a physician, and provides tools for the physicians and the health coaches that include artificial intelligence algorithms that draw some conclusions about what you might want to recommend for the patient. For example, they might observe, we noticed, Bob, that you just can't resist that double cheeseburger every Thursday for lunch. But maybe you might want to just try having that without the top bun and swapping a salad for the fries. Let's just try what that looks like.
I agree.
Or we notice, Vivian, you can't resist that slice of pecan pie, which I have to admit is the weakness. But here, let me just remind you what that has done to your blood sugar the last 3 times you had that. And so we actually provide some of those AI tools to help the practitioner side also align with what's important to the patients as well. That's one example. Lately, we've been really involved in supporting everyone in the COVID crisis. Early on in the pandemic, the state of California reached out to our company because our headquarters is in South San Francisco and said, what can you help us? The area of greatest need that we have is in access to laboratory testing for COVID, which is still a bit of a challenge for in many places, but at the time it was really a crisis. And we had built, as a part of Verily, a set of tools to run clinical research studies and clinical trials called the Baseline Platform. And as a result, it was not that difficult for us to modify that to enable patients or people just to go online, run through the CDC risk questions of, have you been exposed? Do you have symptoms? Are you at higher risk, for example? And if you were at high risk, we used this registry system to be able to set you up so that you could have a lab test ordered. Because there weren't enough testing sites, we actually stood up testing sites. We physically stood these up, sort of pop-up sites, secured the PPE and all the supplies to enable to do community-based COVID testing. First at a few sites in California, and then we extended, working with all kinds of county health departments across the state of California. And then now in partnership with Rite Aid, we've done that across the country. So we've been able to use some of our existing technology to try to help support the country in terms of addressing this COVID crisis. That's been a big focus recently.
That is amazing. I've been to the site there, and I was very impressed with how easy it was to use and the locations that you're serving right now. So we're about out of time, but I'd like to summarize to our listening audience the 3 major principles in the long fix and encourage them to get the book and to read it. It is compelling, but the 3 big major principles in the long fix. Number 1, healthcare is a problem with bipartisan solutions. And number 2, we've talked about this already, pay for results, not action. And the number 3, make healthcare a strategic imperative for the nation. So when people get the book, that will all be addressed. But Dr. Lee, this has been a very good educational session. It's going to be well received in our academic and our industry colleagues. And we can't thank you enough for all the research, the dedication, and the passion you have in creating an action plan that will work for everyone. So we all want to join you in the long fix. So thank you so much for being part of our Business of Healthcare podcast today.
Thank you so much. It's been a real pleasure.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.